lecture. And you can also view the rich content slides he prepared, access our resource center, and receive numerous free knowledge and resource gifts from KnoWEwell and theDr.com to help you and your family on your healing journey. So please come on over to the KnoWEwell platform. I also, for those of you here, want to introduce you to the KnoWEwell webinar platform in case this is your first time, so you can optimize your viewing. If you're on a small screen, you may need to scroll up or down to see some of the features I'm going to tell you about. If you're on a larger screen, you'll see multiple boxes. There's a slide box and there's a video box where you see us. You can expand those or make them smaller for whatever's easier for you to view. There's also a Q&A box, and we invite you to send us your questions and your comments, and we'll do our best to answer as many as we can at the end. There's also a resource box, which I'll talk a little bit more about at the end, and a share your experience widget. And we invite you, if you're enjoying this lecture, to share it out with your friends and colleagues so they can learn about it, because it's not too late for them to join. If you want to learn more about Dr. Tom O'Brien, there's a bio box, as well as you can engage with us on Facebook. So we're very glad that you're here, and I am going to now introduce you to Dr. Tom O'Brien. He's known to many as Dr. Tom. He's a chiropractic doctor, a certified clinical nutritionist, and a diplomat of the American Clinical Board of Nutrition. Dr. Tom holds teaching positions with the Institute for Functional Medicine and the National University of Health Sciences. He's an internationally recognized speaker and book author who focuses on food sensitivities, environmental toxins, and autoimmune disease. He has trained and certified tens of thousands of practitioners around the globe in the advanced understanding of the impact of wheat sensitivity and its impact on autoimmune disease. Dr. Tom is also the founder of theDr.com, the visionary behind the Gluten Summit, one of the first online summits that brought together 29 of the world's experts on the gluten connection to diseases, disorders, symptoms, and ages. And Dr. Tom is the Chief Health Officer here at KnoWEwell. So I'm very pleased to introduce you to him. Welcome, Dr. Tom.
Thank you, Jane Lynn. Thank you so much. Hello, everyone. Welcome. Thank you for taking your valuable time on a Thursday evening, probably after a day of work, to see, well, what's this guy going to talk about? In my opinion, in an hour, you're going to be shutting down your computer, but you'll be in an OMG state. Oh my God, how many patients have I missed that this may have been the problem? So I'm going to start with that introduction, but I do want to do a shout out here. I go on Facebook to see if we're there, and we are there. And I see Emma Ruiz sent me 75 stars. So thank you. That puts me in a great mood right off the bat. Thank you, Emma. That's really kind of you. And Tracy's here from New Jersey, and Crystal's here from Tampa, Florida, and Venetia's here from Melbourne, Australia. Thank you so much. I know that there's hundreds of people here from all over the world, and thank you so much for that. I will do my best to make it worthwhile for you. So let's just get right to it so that there's time for questions. And you can type your questions in the Q&A at any point. And after I get through the presentation, I will answer your questions. Here we go. So in session one about this thing about gluten, I talked about Professor Alessio Fasano, one of my mentors and friends. And he is the chair of pediatric gastroenterology at Mass General at Harvard. He's a professor of pediatrics at Harvard Medical School, a professor of nutrition at Harvard School of Public Health, the director of the Mucosal Immunology Center at Harvard, the director of the Celiac Research Center at Harvard. I mean, it goes on and on with this guy. And any one of these positions is a lifelong goal for people at the top of their field. And given his current positions, we all would have to agree this guy's got something going. He's at a different level than most of us. And he's a big thinker, which is why I appreciate him so much. He's always careful about his language, so that he quoted it. And I want to show you the title of a paper that he put out about a year ago. If you look at the title, all diseases begin in the leaky gut. The role of zonulin, which is the protein that initiates intestinal permeability, the role of zonulin in the pathogenesis of chronic inflammatory diseases. And he says, there's a perfect storm that happens that he's observed and his research teams have observed. And they started this back in 1997 with their first paper on zonulin and intestinal permeability. And they've been doing this now for over 20 years, publishing papers. I see his name come up 20, 30 times a year. His name's on papers. So they're extremely prolific in the work they're doing at Harvard and in other places where Fasano is also associated. But he talks about this perfect storm. And I believe this is the platform that we all need to include as we look at our patients, whether we're looking through the lens of a neurologist or a pediatrician or an allergist or a dermatologist or a proctologist. I believe that this concept of a perfect storm, because it is what causes chronic inflammatory diseases, and whatever your specialty is, what you're seeing all day long is chronic inflammatory diseases. And this is the platform by which they originate and then get fueled. And he talks about the 5 pillars in the development of chronic inflammatory disease. First is your genetics. You can't do anything about that. That's the deck of cards you were dealt. But depending on the paper you read, 70 to 80% of all diseases are not because of the gene. 20 to 30%, if you've got the gene, you're likely going to get the problem. But 70 to 80% says you've got the gene and you may get the problem. And how do you know if you get the problem or not? Well, I explain genes as operating on dimmer switches. There's no on-off switch. There's a dimmer switch, and we want to dim down the genes of inflammation. You don't want to shut them off because inflammation protects us every day. It's excess inflammation that's the problem. And you want to ramp up or brighten up on your dimmer switch the genes of anti-inflammation. And so we know that genetics, you can't change your genetics, but you can influence how that gene is expressing itself. Is it fully bright or is it dimmed down really low? The second of the 5 pillars is environmental triggers. It's the environment that turns on higher or down lower your genes. It's the environment. The environment is the initiator of our genetic expression, the vast majority of the time. And the most common source of environmental influence is what's on the end of your fork. And tonight we're talking about one major concept on the end of your fork, but there's much more than just wheat that we have to think about when we're talking about environmental triggers. Mold in the house, bacterial infections, viral infections, they're all environmental things that can influence our genetic expression. Number 3 of the 5 pillars is altered microbiome, meaning you lose the healthy diversity and you increase the pathogens in the gut, and we call that dysbiosis. But that's number 3 in the development of chronic inflammatory diseases. Number 4, the microbiome creates an inflammatory environment when you're in a dysbiotic state, and that inflammation fuels more intestinal permeability. And that's number 4, the leaky gut, intestinal permeability, which then allows macromolecules, big molecules, to get through the permeable intestine before they've been digested and broken down small enough. That's why your intestines are 20, 25 feet long, is to include, it takes a long time to digest prime rib, not so much to digest a banana, right? So, but when you have intestinal permeability, these macromolecules going on down the intestinal tract, being snipped down smaller and smaller by enzymes, but now this larger macromolecule can get through the leaky gut. And if it gets into circulation, now you activate number 5, systemic immune response. And it's the immune system trying to protect you from whatever got in to the bloodstream. Do you know that 36% of the small molecules in healthy blood, 36% are the metabolites of your microbiome? More than 1/3 of everything in your bloodstream is the exhaust of your microbiome. And if you've got a dysbiotic microbiome, then the messages, because they're all messengers, the messages that are traveling through your bloodstream are to turn up the genes of inflammation. If you've got more of dysbiotic metabolites from your microbiome. That's why it's always so important to include addressing the microbiome when you're dealing with chronic inflammatory diseases, whether it's diabetes or Alzheimer's. You must include dealing with the microbiome, and we'll have sessions on that in the future. So that's the 5 pillars in the development of chronic inflammatory diseases that Professor Fasano talks about. So let's get to it. Here's a first case study for you. So how long has this guy had psoriasis? Look at his body language. He's had it for over 30 years. And he's got slumped shoulders, head's way in front of his shoulders, got a lot of folds in his neck area. This is not a vibrant, dynamic male living to his full potential. This is someone that's been so beat up in life, most likely by how he looks. Kids are chasing each other. They run the elevator and they see him there and they back off, right? They freeze, right? This is pretty severe psoriasis. Same guy, 30 days on a gluten-free diet. That's like, what? What? 16% of all patients with psoriasis have elevated antibodies to gluten with no evidence of celiac disease. So one of our basic premises is that when your immune system is, your antibody level is elevated, your immune system's been activated to work harder to fight something, you have elevated antibodies, you got a problem. And when we talk about predictive autoimmunity and about the science behind that, you'll see that it's critically important to address elevated antibodies before they cause so much tissue damage. Now you get tissue dysfunction, and then eventually you get tissue diagnosis of disease, right? That's elevated antibodies. That sets that up. 16% of all patients they check with psoriasis have elevated antibodies to wheat. Now, that's not supposed to happen. A significant improvement was observed in all 30 patients with elevated gluten antibodies when they were put on a gluten-free diet. This, of course, is the psoriasis, where lesions deteriorated when the ordinary diet was resumed in 18 of 30 patients. For the other 12, I would say, let's just wait a little longer and we'll probably see the same thing. Case study number 2. 28-year-old woman with a 10-year history of chronic inflammatory low back pain, abnormal weakness, she's chronically fatigued, and lack of energy. X-rays revealed evident inflammation of the sacroiliac joints. All blood tests for celiac were negative. Genetically, she didn't carry the genes for celiac, so most doctors say, all right, you don't have a problem with wheat. No, you don't know that. That's an assumption, and it turns out to be an error. But she was positive for HLA-B27. And as you may recall from your genetics classes, that's the gene with exposure to the environmental trigger of Klebsiella pneumoniae, the bacteria Klebsiella pneumoniae, most common infection elders get in hospitals, Klebsiella pneumoniae. And if you carry HLA-B27, you're at high risk that environmental trigger ramps up those genes to develop ankylosing spondylitis. So she carried that gene. And here's her x-rays, and with the joint widening and the sclerosis and the bone marrow edema. We don't need to spend time there tonight. So she carried that gene. They did a biopsy on her, and there was lots of inflammation in the intestines, increased intraepithelial lymphocytes, but no villus atrophy. Plain x-rays revealed sclerosis of both sacroiliac joints with a difficult differential diagnosis between condensing osteitis and sacroiliitis. MRI, there was sclerosis, erosions, bone marrow edema, demonstrating sacroiliitis. Thus, the patient met the assessment of Spondyloarthritis International Society criteria for axial spondyloarthritis. There was a clear improvement in low back pain and fatigue 3 months after initiating the gluten-free diet. Now, there was no evidence to go on a gluten-free diet here. Blood tests for celiac were negative, genetics for celiac were negative, but these rheumatologists, I'm going to show you 4 different case studies from them. They've had decades of experience. And when the medications are not working, let's go right down to, let's put them on a gluten-free diet. And they talk to them in such a way, they look them in the eye, and, you know, like, they're really, I met one of these, the authors of the study, and they say, we look in their eye and we tell them, go completely gluten-free or don't do anything. You'll ruin our reputation if you cheat, right? You want to get well, you stay gluten-free. Because this woman took 3 months to see the improvement in her immobilizing low back pain and her chronic fatigue. 3 months. Now, how many of your patients, if you say, well, it might be a good idea to go gluten-free, how many of your patients are going to be squeaky clean for 3 months? Right? It's the education, and as you experience the results of this type of thinking, you look in their eye and you, with no nonsense, you tell them, this is a 3-month trial with no cheating. If you're not going to do it, don't waste your money or my time. Excuse me, but it's your reputation, right? At 10 months of a gluten-free diet, chronic low back pain had resolved. So, you know, she was better after 3 months. There was noticeable improvement after 3 months. And people want to be well today, right? They don't want to wait. They want to be well right now. Well, in 3 months, she was better, noticeably better. And it took 10 months. Chronic low back pain resolved completely. But if she was exposed to gluten, it would come right back. Here's a case study, same clinic. 50-year-old woman diagnosed with ankylosing spondylitis 3 years earlier, bilateral sacroiliitis on plain x-rays, and she carries HLA-B27, severe, disabling, inflammatory low back pain with an insufficient response to NSAIDs. She had difficult management of her pain due to the coexistence of obesity, spondyloarthrosis, high blood pressure, chronic elevation of liver enzymes, diabetes, autoimmune hypothyroidism, and diarrhea. So this woman is not doing very well at all, and she'd been to many doctors. The pain confined her to a life of crutches and wheelchairs, dependence on others for her personal care. Imagine now, she's obese, she's diabetic, she can't walk, she has diarrhea regularly, and she needs care. Constant care. Blood tests for celiac were negative. Gene tests for celiac were negative. Duodenal biopsy was proposed to her, but she opted to try the gluten-free diet without the duodenal biopsy. Now, that's really impressive that these guys were convincing enough. Maybe she had heard of others who had gotten miracle cures in their clinic. I don't know. But, you know, someone like that is usually not really receptive to doing a complete change of their diet. When they're obese, type 2 diabetes, high blood pressure, increased liver enzymes, you know, the list goes on and on. They're usually more resistant, or they have a difficult time going gluten-free. Her response to the gluten-free diet and some vitamin D was very good. Remission of the disabling low back pain and diarrhea after 7 months. Mechanical low back pain, meaning when she walked, and her severe fatigue continued. So the docs they added milk and dairy. Let's get those out of your diet. And her fatigue improved dramatically. MRI of the sacroiliac joint 17 months after starting the gluten-free diet showed remission of bone marrow edema. You reverse bone marrow edema on a gluten-free diet sometimes. Sometimes, not always, sometimes. She returned to a normal, active life and to work. She did not ingest gluten again. So she had a normal, active life, meaning she didn't need daycare anymore. She wasn't in a wheelchair by going on a gluten-free diet. Here's a 39-year-old guy with a history of over 15 years of chronic low back pain. He'd been diagnosed with psoriatic spondyloarthritis on the basis of sacroiliitis, bone marrow edema, and MRI of the sacroiliac joints, and psoriasis. His conditions were not responding to treatments, and they proposed very powerful tumor necrosis factor inhibitors. He had a son with celiac. He did not have associated GI symptoms. He had no gut problems when he eats sweet. Blood tests for celiac were negative. Gene testing showed he did carry the DQ2 gene for celiac. And until they did a duodenal biopsy, he didn't have celiac, but he had increased IELs, intraepithelial lymphocytes, increased inflammation. So he went gluten-free. These docs looked him in the eye, and he went gluten-free. Low back pain improved notably after around 1 month on a gluten-free diet. Are your patients dedicated enough when every day they're craving the food they've eaten their whole life? And have you educated them well enough so they've got options to choose from of healthy foods? That'll be number 5 in this series that I'll be talking about. But are your patients that dedicated? After a year of follow-up, his low back pain was in full remission. Remember, he had it for 15 years. But it recurred if he ingested gluten. And for this guy, his psoriasis continued. There was some other triggers for psoriasis. Here's a 51-year-old woman who was followed at another center for anti-CCP, positive erosive rheumatoid arthritis. Her clinical situation, one poor control despite treatment with chemical and biological agents. She wasn't responding. Her disease was resistant to treatment with anti-tumor necrosis factor, and she'd been included in clinical trials involving new biological agents. Currently, she's on methotrexate, rituximab, corticosteroids, indomethacin, proton pump inhibitors, and sertraline. I mean, how would you treat this person? What would you do when someone comes in like this? Although joint inflammation was reasonably controlled with immunosuppressive therapy, she was experiencing pain, severe fatigue, diarrhea, bloating, and oral ulcers, mouth ulcers. The pain and severe fatigue confined her to a life of dependence on others, meaning she's in a wheelchair. People have to cook for her. People have to do her laundry. Serology for celiac was negative, but they convinced her to try a gluten-free diet. Gluten-free diet was followed by a clear improvement in all her symptoms within 6 months, every one of them. After 4 years of adherence to gluten-free diet, she remained in excellent clinical condition. She wasn't in a wheelchair anymore. She's able to lead an independent life with excursions to the countryside. She can dance the Zumba. She continued treatment with oral methotrexate and prednisone. So just the gluten-free diet. If she ingested gluten, she'd experience recurrence of diarrhea, asthenia, and arthritis, corroborating her gluten sensitivity without celiac disease. Here's a 39-year-old woman referred for symmetric polyarthritis, including a 6-year history of metacarpal phalangeal joint, proximal interphalangeal joint involvement, negative for rheumatoid, negative for CCP, negative for ANA, negative for HLA-B27, and she'd already been treated with corticosteroids and had a little bit of improvement, but still severe fatigue, oral ulcers, history of iron deficient anemia. She had a previous diagnosis of IBS. Blood tests for celiac were negative. HLA typing revealed the presence of DQ8. The duodenal biopsy showed that she had 34 lymphocytes per 100. Anything over 25 is inflammation, increased inflammation. 9 months after initiating the gluten-free diet, would you put this patient on a gluten-free diet? What criteria could you defend it with? There was nothing in these tests to defend recommending a gluten-free diet. But all these patients I'm showing you, there was nothing that indicated they needed to go gluten-free. No blood test was positive. But these doctors have seen such dramatic results with so many patients over the decades that when nothing else works, that's the first thing they do is put them gluten-free. And I'm just picking out 7 of them here to show you tonight. But you know, there are hundreds and hundreds of cases like this. 9 months after initiating gluten-free diet, all of her symptoms were in remission. As she was asymptomatic, she continued to take only 1.5 grams of her medications, previously diagnosed anemia had resolved. 2 years after initiating gluten-free diet, she's completely asymptomatic without medication. Here's a 49-year-old woman diagnosed with limited systemic sclerosis, Raynaud's phenomenon. She had elevated anti-centromere antibodies. That's the diagnosis for scleroderma. Her hemoglobin was a little low. Gastroscopy revealed hypertensive gastropathy with gastric angiodysplasia, the watermelon stomach. What does that mean? Well, that's the watermelon stomach when you do a gastroscopy. That it looks like a watermelon, right? Clinical picture, she'd been this way for 4 years, severe fatigue, poor memory and concentration, bloating, intermittent diarrhea, gastroesophageal reflux, oral ulcers, unable to tolerate corticosteroids. Staining the duodenal biopsy sheds, which had been normal in the past, now showed a low level of inflammation, and she carried the celiac gene. They convinced her, she did a gluten-free diet. 6 months after initiating a gluten-free diet, her GI symptoms, her fatigue, her Raynaud's phenomenon had improved. She had discontinued her medications, which she'd been taking previously, took a multiple with some minerals, CoQ10, and omega-3s. 18 months on the gluten-free diet, asymptomatic, and GI symptoms, fatigue, and mental fatigue had all resolved. Raynaud's phenomenon appeared occasionally. She tested positive for anti-centromere antibodies. Occasional gluten ingestion had been followed immediately by fatigue, oral ulcers, and recurrence of her GI symptoms. So gluten's not the miracle by itself, but it's a critical component for so many people out there. In our experience, the most important clinical data that indicate the presence of non-celiac gluten sensitivity are severe fatigue of unknown etiology, meaning it's not anemia, oral ulcers, the associated GI symptoms, iron deficient anemia, and having a relative with celiac. If they've got any of those criteria, they are aggressive, recommending a gluten-free diet. And you've seen the results from that. So what about the brain and the nervous system? That's musculoskeletal. Now let's do a little brain. There's substantial evidence that depending on genes carried by over 1/3 of us have the genes for celiac, DQ2 or DQ8. Over 1/3 of us. But only 1 to 4% get celiac, depending on what country you're looking at. But wait, you carry the gene. Well, that's an important component, but that's not all that's required to develop celiac disease. It's the 5 pillars that Fasano talked about. That's required to develop celiac disease. The microbiome, the intestinal permeability, the environmental trigger, gluten for celiac disease, causing that inflammatory microbiome, creating the intestinal permeability, the systemic circulation, and systemic inflammatory response. There's now substantial evidence, depending on genes carried by over 1/3 of us and on seemingly irrelevant factors, such as a previous viral infection, eating bread can adversely affect our body and brain. Unfortunately, gluten resembles some brain-relevant substances. In vitro, antibodies against gluten removed from human blood attack cerebellar proteins and components of the myelin sheath that insulates nerves. That's molecular mimicry. I have an entire all-day course on that, on gluten sensitivity, molecular mimicry, and development of autoimmune diseases. They also attack an enzyme involved in the production of GABA and our prime inhibitory neurotransmitter, whose dysregulation is implicated in both anxiety and depression. And if you have the antibodies to what's the enzyme? Glutamic acid decarboxylase. That's the enzymes that get because of a gluten sensitivity, a high percentage of people can have the enzymes to GAD, glutamic acid decarboxylase, and then you can't convert glutamine to GABA. It won't go there. The enzyme glutamic acid decarboxylase is required for the conversion. There's a 2-step process to get to GABA from glutamine, but your body can't do it if you have elevated antibodies to glutamic acid decarboxylase, and it's really common. In my practice, 22% of everyone I checked for sensitivity had antibodies to glutamic acid decarboxylase. And they often had associated anxiety or depression, which would go right along with low GABA levels. Among individuals with a normal intestinal wall, those who carry blood markers of celiac are 3 times more likely to develop autism in the future, 5 times more likely to have already been diagnosed with it. In several countries, hospitalization rates for schizophrenia during World War II dropped in direct proportions to wheat shortages. When you read the studies on this, it says, wow, that just makes sense. In the United States, which over that same time period, the consumption of wheat rose rather than diminished, such rates increased. Schizophrenic diagnosis increased during World War II. Just go back and look at the science. Bread consumption goes up, schizophrenia goes up. In Europe, bread consumption went down. In many countries, schizophrenia went down. In the South Pacific Islands, with the traditionally low consumption of wheat, schizophrenia rose dramatically from 1 out of 30,000 to 1 out of 100 when Western grain products were introduced. It's because primarily because of the gluteomorphins in wheat. The gluteomorphins bind to the opiate receptors, not only in the brain, also in your gut and throughout the body, but the gluteomorphins will activate the opiate receptors. Feel good. The opiate receptors are there, like my son, our 9-week-old son, is breastfeeding. And one of the reasons that infants always go for the breast, always go for that milk, is because mom's breast milk contains opiate-like compounds that it's Mother Nature's way of making sure baby wants the milk. So baby takes in these opiates in the milk, which stimulate feel good. And the result is baby just automatically goes for more. It's not a conscious thought. It's a reflex. When you're trying to take people off of wheat, and if they have elevated antibodies to the gluteomorphins in wheat, and you can do that test, we'll talk about that in a future session, and they've got elevated antibodies to the gluteomorphins, and you take them off wheat, they crave wheat. They want it because they've had that receptor stimulated again and again and again and again. Toast for breakfast, sandwich for lunch, pasta for dinner, croutons on your salad, a cookie. Your medications may have wheat in them. Your vitamins may have wheat in them that were exposed multiple times a day, every day. And if you have a sensitivity to the gluteomorphins in wheat, it's going to affect your brain. And those are the people that we transition very slowly onto a gluten-free diet. Just go to Google. Oops, let me back up, sorry. Get a little excited there. Just go to Google and type in schizophrenia and gluten and look at the hundreds of studies in psychiatry journals. It'll just drop your jaw. You say, what? What? A postmortem study of 82 schizophrenic patients found rates of stomach inflammation, small intestinal inflammation, and large intestinal inflammation at 50%, 88%, 92%. Their guts are inflamed. Schizophrenics' guts are inflamed. It's inflamed because of an environmental trigger that causes the inflammation in their gut, right? In all of us, zonulin increases the permeability, not only of the intestinal wall, but also of other no less interesting barriers, notably the blood-brain barrier. And we have a whole session on this. When you diagnose leaky gut, you assume most likely they've also got leaky brain. Won't take the time to talk about that today, but in a future session we will. If gluten is not withdrawn during childhood, the growth of some cranial bones is altered as well. As a result, over 80% of adult celiacs have unusual facial proportions. Quite typical is an especially high forehead, relative either to the middle third of the face or to the forehead of healthy people. Look at my forehead. You're supposed to go from the bottom of the chin to the bottom of the nose, same distance, should hit the hairline. Mine does not hit the hairline. That's an enlarged forehead. Development of the front of the skull of patients with celiac reveals an altered pattern of craniofacial growth. A large forehead is a sign easily evident visually or with very simple measurements. Computer analysis is not required for the general practitioner. This sign, along with the presence of other clinical signs and symptoms, should alert a physician to test a patient for celiac disease. And I would say, because this was back in 2005, this study is 15 years old already, but I would say you test them for a wheat-related disorder, not just celiac disease. And you include celiac, but you test for much more. This alteration is a clinical sign that should be included among the extraintestinal manifestations of celiac. It has a frequency comparable to other signs or symptoms, such as anemia and short stature, and is a better predictor of celiac than other signs, such as recurrent aphthous stomatitis, sores in the corners of your mouth, recurrent miscarriages, and dental enamel hypoplasia. So look at this woman's forehead. Go from the bottom of the chin to the bottom of the nose and go thirds to reach the hairline. And you see that her forehead is larger, that the middle section of her facial structure is shorter than the bottom section or the top. Same woman is on the left, a normal skull on the right. And you can see the differences. And when I'm on stage doing talks, yes, celiac, 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 celiac. And I would wager these people, I've done it before, and never lost, but I've never collected either. You know, I say, I'll wager $100 if you do the right test, you've got elevated antibodies to wheat, right? And every time. So far, every time. And so what happens when they reach out and say, oh, doc, you were right, you're right. Well, where do I send you $100? I say, no. You know, next time we're at a seminar together, you buy me a glass of wine, right? But it's so very common to see. The frontal facial development appears to be more influenced by epigenetics, what's on the end of your fork, than the skull. Vertical growth of the cranium is more affected by gluten intake in gluten-sensitive individuals in the first 5 years of life. And here's where it's really important. In fact, celiac patients of our series with very early disease diagnosis on strict gluten-free diets during childhood do not show the described craniofacial characteristics their older siblings have. They don't develop the large forehead their two brothers have when they're gluten-free before the age of 5. What? What kind of an influence would that have on a child's development or a child's brain development? Well, we know about craniosacral therapy, and the very softest of techniques can have a profound impact sometimes when you're working with a patient's skull. Well, let's just stretch that skull out over the first 5 to 7 years. And then imagine how that brain functions and how the communication comes out of the foramen to travel down into the body, right? Nobody knows. No one's followed that. But I can only assume that a well-rounded facial structure has more balance and symmetry and neural function and lymphatic drainage, glymphatic drainage. I can only assume that as one of the factors that may give a person a better shot at having healthy brain function is to have a balanced skull development. Okay. Here's a 32-year-old guy with a 1-year history of balance. I mean, he was losing his balance. And for the last week, it had been getting a lot worse. So he finally got into the neurologist. And he had hand tremors and gait disturbances. At admission, they found out that he had lost 60 pounds in the last year because of diarrhea 3 to 4 times a day. Well, you think? I mean, what's going on in the gut? Physical exam showed a broad-based gait, leaning to the right, dysmetria with right finger to nose, hyperreflexia, an upgoing right toe, right lower extremity weakness, and right foot drop. You see this in a 31-year-old guy? What do you think? Yeah, just like the title, amyotrophic lateral sclerosis, right? Laboratory studies were pretty normal. Just a slightly elevated phosphorus, everything else was okay, but his brain MRI showed multiple lesions in the brain. Look at those. 31-year-old guy. Where are these white matter lesions coming from? Initial diagnostic considerations were amyotrophic lateral sclerosis and Friedreich ataxia. Ataxia workup, because they thought he may have ataxia. One of the things they have to rule out, of course, is gluten ataxia. So they did a blood test, and he came back elevated antimysial antibodies. So they did endoscopy. Yeah, he's got celiac. This guy's got celiac. Started a gluten-free diet with improvement of symptoms during the next several months. Repeat MRIs, 23 months later, almost 2 years later, the lesions are gone. You reverse lesions in the brain on a gluten-free diet sometimes. In my all-day course, I've got 5 studies, and I show you the MRIs, reversing lesions in the brain on a gluten-free diet. This is the American Journal of Neuroradiology. So if anyone had said to me before I started reading these studies, yeah, change your diet, eat what I tell you to, and we'll get rid of those lesions in your brain, I'd say, don't ever go back to see that guy again. Reversing lesions in the brain is not something you hear very often. I've got 5 studies from the journals in my all-day course, and this guy is one of them. His symptoms and his MRI lesions improved and resolved completely on a gluten-free diet. Here's a case, really love this one. 3-year-old girl, had lots of gut problems. They went to a gastroenterologist and did an endoscopy. He put her under general anesthesia, did an endoscopy, and said, your daughter's got celiac disease, severe. Put her on a gluten-free diet immediately. Parents said, okay. But there's something wrong with your daughter's eye. We're going to get you into the ophthalmologist right away. Okay, so the parents put their child on a gluten-free diet, but they're in the ophthalmologist's office 2 days later. And what do they find? So here the little girl's looking down, and they're lifting the eyelid up. That's a tumor on her eyeball. And the presumed diagnosis was conjunctival Kaposi sarcoma. Why? Because mom was HIV positive, but the little girl was HIV negative. So they said, well, what is this? Well, we don't know. So parents, we're going to have to do a biopsy of your daughter's eye. And the parents said, oh, okay. But we'll give her general anesthetic for, oh no, please don't give her general anesthetic. Our daughter hasn't recovered from the general anesthetic a few days ago for the endoscopy for celiac disease diagnosis. We put her on a gluten-free diet, but she hasn't recovered yet. Can we wait a few days, please? And so the ophthalmologist said, okay. And they came back just about a week later. And what did they find? The lesion was a week later and 2 months later, completely reversed. No treatment was done except a gluten-free diet. You reverse a conjunctival Kaposi sarcoma, that was the diagnosis they were going to give her, on a gluten-free diet. Completely asymptomatic 9 months later, and that's when they wrote the case up. We present a very unusual conjunctival tumor in a patient with celiac, showed complete regression by a gluten-free diet. Prompt regression of the lesion during gluten-free diet suggests a possible relationship to celiac and an autoimmune process. This is a molecular mimicry thing. I'm showing you here just musculoskeletal neurology tonight. We could do cardiac, we could do hepatic, we could do dermatology, and there's study after study after study on these things. Last case. This one is so important. 14-year-old girl. Now, in Italy, there are 36 centers that are designated gluten-related disorder centers by the government. What that means is if you get a diagnosis of a problem with wheat from one of these centers, 36 of the psychiatrist that was working with her sent her to one of these clinics, certified clinics, because you'll see they found out eventually gluten seemed to be a problem. In May of 2012, after a fever, she became increasingly irritable, had daily headaches, concentration difficulties. A month later, her symptoms worsened, presenting with severe headaches, sleep problems, behavior alterations, several unmotivated crying spells, and apathy. This was a healthy 14-year-old girl on the swimming team at her school. Her school performance deteriorated, reported by teachers. Her mother noted severe bad breath, never suffered before. Well, that's a big clue right there. What's wrong with the gut? The patient was referred to a local neuropsychiatric. Let me back up to that. What's wrong with the gut? Some of you know that for every message going from the brain down to the gut, there are 9 messages from the gut going up to the brain. The metabolites of the microbiome, a third of everything in your bloodstream, the metabolites of the microbiome are messengers that activate different genes in the brain. The ratio is 9-to-1. It was Dr. Michael Gerber who wrote the book, The Second Brain, in 1999. He's at Princeton. He talked about this, the 9-to-1 ratio. So psychiatrists need to learn this, because you have a psychiatric patient that's got really bad breath, never before, and but they put her in a psychiatric ward at 14 years old. Oh, I think I skipped a slide with the diagnosis. Let's see. During the final school exam, psychiatric symptoms occurred sporadically. In previous 2 months, they got worse. She began to have complex hallucinations. The types of these hallucinations varied and report is indistinguishable from reality. She saw people coming out of the television to follow and chase her. Somehow I missed the slide. But they put her in a psychiatric ward. CT of the brain, blood pressure Holter also performed, resulted normal. EEG showed mild non-specific abnormalities and slow wave pattern. When you have a slow wave activity, that is a slam dunk. On an EEG, you got to check for a wheat-related disorder. This is what brain fog is. People get a little brain fog when they eat pasta or something. They just can't focus really well. That's of a problem, but they put her on steroids now too. By September, shortly after eating pasta, she had crying spells, confusion, ataxia, severe anxiety, paranoid delirium, again referred to and admitted to the psychiatric unit. And they suspected the recurrence of symptoms was because of a relapse of autoimmune encephalitis, which they didn't diagnose the first time, and they didn't diagnose it here either. But they put her on more steroids and admitted increase in fecal calprotectin. The calprotectin means inflammation in your gut. All the markers for celiac were negative. What kind of courage does it take here to think about gluten when celiac is negative? In September, she presented with severe abdominal pain with asthenia, slowed speech, depression, distorted paranoid thinking, suicidal ideation. This is your 15-year-old daughter now. Now, due to GI symptoms and further weight loss, 15% of her body weight she's now lost. A nutritionist said, why don't we just try a gluten-free diet? Let's just try it and see what happens, right? Within a week, her symptoms were dramatically improved. Within a week. And the gluten-free diet was continued from there on, and all of her symptoms resolved. Until a few years ago, the several hospitalizations a year, second generation antipsychotic medications, nothing's working. She's still suffering, seeing things jump out of the TV, chasing her. What kind of a life was in front of her? If someone didn't have the guts to say, why don't we just try this? Why don't we just try it? It's not going to hurt you. Let's just try it. It might help. I know it sounds weird, but it might help. Due to parental choice, the girl did not consume gluten, and she started a gluten-free diet with a complete regression of all symptoms within 1 week. Her mother recalled that she was finally returned a normal girl. 9 months after definitely starting the gluten-free diet, she is still symptom-free. So all of these case studies that I've given you, all of them, I hope it just stimulates you, it piques you, and you want to learn more. This is a paradigm-shifting line of thinking that'll enhance the health of you and your family substantially. And with that, I'm going to say thank you for your kind attention and turn it over to Jane Lynn.
E3, which I understand is very common. Anything you can recommend as I get older?
Yes, that's a great question, Becky. Great way of asking the question. So what she's saying is that she's got the average gene for Alzheimer's. And I also am a 3-3. And when I discovered I was a 3-3, I have to admit it was a sigh of relief. I wish I had a 2 in there, because you can be a 2, a 3, or a 4. And you get one from your mother and one from your father. So you're a 2-2, 2-3, 2-4, 3-3, 3-4, 4-4. You know, those are the only options. And I'm a 3-3 also. And I felt a sigh of relief. That means that 50% of us with a 3-3 will have Alzheimer's by the age of 55, by the age of 80, excuse me. It's the age of 80, 50% of us. If we carry 1-4, it's 50% of us by the age of 65. If we carry 2 4s, you're a 4-4, it's 90% of us by the age of 65. So the gene is a biomarker that says, you got a problem here, you're very vulnerable, but it doesn't mean you get the disease. It means you're extremely vulnerable to the disease. So a 3-3, you're average. What else can you do is a great question, just a fabulous question. And now, you know, I'm so happy for the last few years, I can tell you exactly what to do. You do the Neurolzoomer Plus. It's a blood test that has 97 to 99% sensitivity and 98 to 100% specificity. And it looks at 48 biomarkers of brain inflammation. 48, with such a high degree of accuracy. So proud of that test. I wish I had some stock in the lab. That the lab is vibrant, and I wish I had some stock, but I don't. And you can go to my website, theDr.com, and go there and look under tests. Look at the Neurolzoomer Plus. Download the information. Order the test yourself if you're a practitioner, or have your doc order it for you. If they refuse, you can order it on my site. We'll send you the test kit. It's fine. And that test also can be done with a finger prick now, with the same sensitivity and specificity. But that is the most sensitive biomarker in the world. Is my brain inflamed? Because systemic inflammation is one of the 5 pillars in the development of chronic inflammatory disease, right? And so you want to make sure your brain is not inflamed. And quite honestly, every single one that we've done on a first test have come back positive. The brain is a canary in the coal mine. You're going to see problems there first before other areas. And because of the extremely toxic world we live in, we're inhaling benzene when we fill our cars with fuel. I won't go into it now. We'll have a session on it down the road. But the first test is often, I've never seen a negative come back on a first test. On the follow-up test in 6 months or a year, you better be much better, if not completely negative. But that's what I would do. No question.
Thank you for that. And Elise asks, what is going on when the client has been gluten-free, dairy-free for months, yet has the same symptoms as for gluten when they eat non-gluten grains and starches?
Yeah, it's most likely the microbiome. Dealing with the environmental trigger is a critical component. Stop throwing gasoline on the fire. And so going gluten-free is critically important. By the way, the test for that, and we'll talk about tests in a future one, but it's the wheat zoomer. I talked about NeuroZoomer Plus, the wheat zoom, best test in the world, and I'll explain why in the session we do on that. The microbiome molds and adapts every day to what we're feeding it. And over the years of eating foods that create an inflammatory state in the gut, you develop an inflammatory microbiome. And so you take gluten out of the diet, you stop throwing gasoline on the fire, great, but you got a roaring fire here, right? So you always have to address the microbiome with the other therapies that you're doing. And there certainly can be other foods besides dairy and sugar. Way to go to have those out of there. Those are critical. But there are many other foods that could do it. Or if the person has a yeast infection, for example, candida can cross-react. So your immune system makes antibodies to fight candida. And the protein signature of the candida, the component of candida that the antibodies are targeted to go after, is a very similar protein structure to gluten. And so the antibodies to candida can be activating, and create the antibodies to gluten. Even though you're not eating gluten, you still have elevated antibodies.
This is great. This is packed with great information, a lot to take in. Thank you. And we've had several people ask if we're sharing the slides. And so, yes, tomorrow, when you register for the webinar, not only can you attend it live, but the day after, you do receive an email with a link to the recording, and you will see the entire webinar platform with that recording. So you'll get to not only hear Dr. Tom again, but see the slides again that way. So we're really great. I'm really happy that you joined us. And Marianne says, great presentation. Thank you.
Thank you so much. Thank you for that.
Let's see. I do have one final thing that came in. So why don't we take a moment for this one? Wow, this was fantastic. Thank you, Dr. Tom O'Brien. You made such incredible connections. Would you have thought of such unexpected links between various symptoms and organ systems? Or who would have thought? Who would have thought?
Yeah, I understand. I understand. No, that's a really good. I understand. She's in the OMG state right now. Oh my God! Who would have thought? You're absolutely right. And what you get to, if you keep reading, I've been reading about this since 2004, and literally thousands of studies in this computer that I've downloaded and read, literally. And what the stage that you get to in your understanding is that what Fasano is talking about, which is why I start these talks with Fasano's message. The 5 pillars in the development of all chronic inflammatory diseases. It doesn't matter if you've got rheumatoid or lupus, MS or conjunctival tumor. It doesn't matter. If it's a chronic inflammatory state, these are the 5 pillars that created the environment for that chronic inflammatory state. So when you look, okay, number 2, the environmental triggers. And as you start reading more and more, you take my course and you'll know everything after that, or you have access to it after that. You see that, boy, when I throw gasoline on the fire, I get seizures. I mean, in gastroenterology, they published a paper, 50% of children with drug-resistant epilepsy, which by definition means 3 drugs that didn't work and the kids still get seizures. 50% of them go into complete remission on a gluten-free diet. 50%. It's like, what? How come our neurologists don't know this? Because they don't read gastroenterology journals. They read neurology journals, right? And so you start to see that our entire healthcare system is in silos. And whether it's ophthalmology, cardiology, hepatology, obstetrics and gynecology, pediatrics, allergies, we've been trained to think like this. And when you get the Fasano concept here of the 5 pillars and development of the perfect storm for chronic inflammatory diseases, you think like this. This is the psychiatrist who checks all of his schizophrenic patients to see if they have a problem with weed or not, because he's thinking like this now. Or this is the cardiologist that knows congestive heart failure can be about 20% of the time from a sensitivity to wheat. And you take wheat out of the diet and the ejection fraction goes up within a week or two. What? So your question's really good, because who would have thought? Because we think in silos. When you don't think in silos anymore and you open up, you'll find out that mold can create all of the same symptoms that a gluten sensitivity can, if mold is the environmental trigger. Or petrochemicals, if they accumulate in your body. Every newborn child's got over 200 chemicals in the cord blood at birth, and none of them are supposed to be there. Those 200 chemicals that aren't supposed to be there, and many of them are neurotoxins. Every child. And we just ignore. They say, oh, that's too bad. Well, imagine the bloodstream and all this toxic crud that's in there. And then just go to Google and type in phthalates and neurogenesis. And here come the studies that when you have increased levels of phthalates in your bloodstream, neurogenesis is compromised. So I love the question, because you're on the edge. You know, you're right on the edge of going like this. Who would have thought? Who would have thought? Anyone who's living in the silo will not think of this. We, of course, practice in our silos, but as you've been in your silo for 20, 30 years, you start opening the boundaries a little bit. And the goal here in our series, and my goal as Chief Health Officer for KnoWEwell, is that we all develop more of this, so that we can be in our silos, but we see more of what might be contributing to whatever the symptoms are that come in to see us. So I thought that's a great question. Thank you so much for asking that one.
That was fantastic. We love learning from you, Dr. Tom, and thank you so much for sharing your expertise with us this evening.
Thank you so much, Jane Lynn.
And as an additional thank you to those of you who have joined us this evening, Dr. Tom is giving us access to his educational gut resource guides in Dr. Tom's Clinical Pearls topic group, which is in the KnoWEwell community. And if you're not already a member of KnoWEwell, well, please accept our gift of a free membership. You can learn more about KnoWEwell and how to sign up by downloading the PDF in that resource box on your screen that I told you about. And just to give you a minute to do that, if you're interested, I'm just going to quickly tell you a little bit about KnoWEwell. We're the global regenerative whole health benefits and services company. We offer today's trusted regenerative whole health knowledge, resources, healing success stories, access to evidence-based resources, and we create meaningful connections to help you throughout your life's healing journey. And we hope to see you in the community with us. We also hope to see you next week, or I'm sorry, it's actually on March 18th at 7 p.m. Eastern, when we come back together for part 3 of this 5-part series. And Dr. Tom will talk about patient success stories and obscure recovery examples. Thank you again for joining